Excellent. Gosh, two amazing talks and lots of substrate. Got me thinking a lot. And I can see the questions in the chat are coming in thick and fast. That's fantastic. So I'm going to kick off with a question. We've talked about different models, structured handovers, joint clinics. What do you think works best? And what do you think is the hardest? What do you find the most challenging in your practice? So I'll give Priya a little bit of a rest to regain some voice. And so perhaps Alexis, you can kick off.
So I'll start with, so first of all, we don't have the ability to do it together, but I do like when we go back and forth because it gives them a little time to kind of settle in a little bit and it gives us time to discuss. So after I've seen the patient, then I can have a different kind of discussion with the pediatric rheumatologist than if I'm discussing before I see them. It also gives me time to clarify some things, and then the patient comes, and I'm like, "What do you mean enthesitis of like your ankle? What did that mean? You know?" And so we can get a little more clarity on some of the features. Uh, and then what's hardest for me is the parents. So when the parents come in, I think the parents have a harder time with the transition. And so I remember one particular 20-year-old or something, he came with his mom, and the mom took over most of the visit with questions, and she was talking for her son and stuff like that. And I talked, then he went back to his pediatric rheumatologist, and I was talking to the pediatric rheumatologist, and she said, I knew that was going to happen. I told her not to do that. I told her she should step out of the room. But it was like an opportunity also for her to re-educate mom that mom needed to step back a little bit and, let the son go, take over his own care. So I think that is most challenging as parents to me.
Yeah, very interesting in terms of the balancing of autonomy, but also the vulnerability that they have as well. So I can imagine it's really difficult for parents, but also challenging all round. Priya, what do you think? What's the best model? And also, what do you find the hardest in real world clinical practice?
Thank you. And I think the best model is when sort of the pediatric and adult professionals are working together, and there are lots of different ways of doing that. And it it may be different in different countries and how the services have been set up and funded, etc. But I think when professionals work together and they work with the young person and the family, I think that's when it works really well. That's when it works really well. What's hardest? I think what I find hard is when there is a lot of complexity, when it's not just a straightforward one condition, when there is a lot of complexity that needs teasing out and working through. And then potentially when there isn't a mirror service to transition care to for some aspects. So there are some aspects which are, sort of really good. So inflammatory bowel disease, there will be an adult gastroenterologist, there'll be an adult IBD nurse. But if there are other things involved and there isn't a mirror service to transfer to or transition to, that's really hard.
Mm. No, no, absolutely. And just coming on to that point, do you think that transition services work better if they're disease specific or a unified approach that could be applicable to lots of different diseases? So, Alexis, as a rheumatologist, we have multi-system conditions, uveitis, the gastro, the renal, and so on. What do you think works best?
Yeah, I suppose I'm a little biased in this because I am in a specialty setting. So I only see patients with inflammatory arthritis. And that I think and again, my biased opinion is that subspecialty specific is helpful. So that because we know we're going to end up working with gastroenterologists or ophthalmologists or, um, I guess there's two frames though. Like one is rheumatology versus gastroenterology. The other is inflammatory arthritis versus Crohn's disease versus, and so on, or lupus. I think lupus is just altogether another beast, and it's just a different set of things that we're worried about. And that is where we have much more tight connections within our transitions program because those lupus patients are more apt to be lost to follow up, and there's socioeconomic reasons for that as well. And so it's just different. And so I think having that set of different pathways is helpful so that we're, watching out for the same things and in the individual pieces, and then also tailoring the transition to the individual patient. But I'd be interested to hear what Priya thinks about that.
We're coming.
Thanks. I think I agree with you, Alexis. I think there is something to be said about transition across sort of the specialty pathway. So there are going to be some specialty specific elements on transition that the specialists need to provide around their disease education, their medication education, which is going to be unique and specific to that particular specialty. But there are also going to be some generic aspects on transition, so sort of the health promotion aspects around it, around adolescents. And I suppose my take on that is if we were all sort of practicing developmentally appropriate healthcare across specialties, across pediatrics and adult healthcare, then I think transition would perhaps be easier because we would all be doing similar things. I think having a combined lots of ology clinic, I think the logistics of that might be really tricky. And I'm not sure how that would be funded in any healthcare model. But yeah, I mean, that would be sort of, yeah, that would be something interesting to think about. But I think practically, transition will happen across specialty pathways, and I think it's all of us thinking about that concept of ensuring that there is that health education and health promotion happening as we're delivering healthcare transition.
Thank you. Let's talk about digital solutions. And Alexis, I think you talked about booking appointments on the pediatric app and then the adult app and creaky joints. And in the UK, we have similar educational streams online. Our young people may be more tech savvy than their doctors. So how can we bring in, Priya's shaking her head, so maybe you're great at this, but perhaps there are more things that we can bring in to improve streamlining transitional service, making that transition smoother using digital solutions. I was hoping that you could talk about this a little bit, Alexis.
Yeah, I think that they adapt the technologies really quickly too, and they're much more open to thinking about these technologies. So even in terms of thinking about sleep or something, many of them are used to having devices. And so as we're talking about how sleep is so tied to your arthritis, they're like, oh, cool, I can measure that. I can look at that on my app and like, make something out of that. And so whereas the adult is like, I don't want to wear a device to bed, so I think, and that's not universally true, obviously, as I wear my Aura ring on my hand, but I think one of the things that is fun about that is that you can develop individual pathways with them. And so in in the United States, Creaky Joints has an app. It used to be called Arthritis Power, but now it's called Patient Spot. But on there, they can track what's going on. And so if they want to institute a dietary change and see how it goes, they can keep their global assessment over the course of 8 weeks and then see if there's a difference. And I think it's an empowerment thing, but also embedded within there are pieces of education and things that they can learn about, and then they're learning about themselves. And I think there's an aptitude to do that is different. And so I think that's really fun. Being a device and wearables and technology person, I love that about the younger population too.
Yeah, Priya.
Thanks. Yeah, no, I like the rheumatology world. I think there are sort of lots of tech things or solutions on offer in inflammatory bowel disease world as well. And I think young people do like engaging with them, and there is something about education, their role in providing more education and empowerment. I think what I would like to see is, however, more sort of robust research around this as well, in terms of do they really have an impact and what's the impact that they do. There was work done with colleagues that was published that looked at there was a James Lind Alliance priority setting partnership that looked at the role of digital health technology for young people with inflammatory bowel disease. And this priority setting partnership is to try and establish the top 10 research priorities. It also looks at what's published in the literature when the priorities are finally chosen. And what was interesting was that one of the top 10 was whether digital health technology does support healthcare transition for young people with inflammatory bowel disease. So I think that still hasn't been robustly answered, although we do have lots of technology out there that young people can try. So I think it would be nice to see that part being answered with good research.
Thank you. That's a nice segue onto my next question, which has come from the audience, which is about the role of research. So rather than the impact of digital technology on pediatric and transitional outcomes, can we use digital technology as data mining for data capture? What are the big research gaps in transitional care in rheumatology and inflammatory bowel disease, and how can we address them? So perhaps, Alexis, I can go to you first.
Yeah, I think a lot of there's lots of different types of transition readiness assessments, and then there's different types of transition programs. But I would like to see more digital methods for helping with transition and something to help teach young people about how to navigate the health system, which I mean, you teach anybody how to do that in the US because it's so complex. We should try to teach everybody how to do that, I guess what I should say. But they may be good, targets for the digital pieces of that. So I think kind of back to what Priya just mentioned, knowing how well these different interventions work would be helpful. And I think along with that, teaching self-management strategies in that same way.
Thank you. Priya.
Thanks. It was just making me reflect on. So it was an interesting question about using digital technology and for sort of capturing data and research. And it was just made me think about an umbrella review that was published around efficacy of digital health technology in managing inflammatory bowel disease. And I think what the conclusion of that umbrella review was that it could potentially help with sort of in using digital technology in addition to standard clinical care could help with sort of reducing hospital visits. But there was it was also exploring the potential of using more digital technology for data capture and sort of in a research setting. So that sort of emerged from that umbrella review. So I think that's a really interesting question and something I think, yeah, watch the space. Who knows what's going to come out in the future with that.
Yeah, thank you. And our registrant also commented on perhaps this could drive conversations with healthcare commissioners to secure funding for transitional care. So on that, in that vein, metrics of success, because we've talked about how hard it is and all the challenges, but how do we know that we're doing well? So is it disease outcomes? Is it attendance actually coming to clinic? Is it patient satisfaction? What do you think is probably the best way to measure and what is more feasible? And what do you do right now? So Alexis, thank you. If you could, metrics of success.
Yeah, I think actually the three you mentioned are probably the key ones. So do they come? Do they keep
Mhm.
coming? Are they happy with with the care? And then are they taking their medicines and are they doing well? So I think doing well is obviously the ultimate outcome. We want them to keep feeling well. But those other ones are nice surrogate outcomes too.
And I think all of them could be captured electronically. I mean, patient-reported outcome measures are so hard to get in our older patients, and I can just imagine our adolescents and young people being able to quickly whiz through an app and capture all of those, I think. Priya, what do you do in your clinic?
So I wish I had an app to capture all of that, but we don't. But yeah, I mean, metrics of success, absolutely. Disease outcome, are they functioning how they want to function, doing what they want to be doing? But I suppose another one is around patient experience. One of the things that we try and capture within our pathway is capturing patient experience of healthcare transition, and then that helps sort of improve, develop the offer that's out there in terms of what we're currently doing. And we've used a sort of validated questionnaire, Mind the Gap, quite recently to try and capture. It's quite a nice questionnaire, so it asks young people what they think would be best practice, and then it asks them what they received in their clinical care, and then it sort of tells the healthcare professional what the gap is. So it's quite nice in that sense, but hopefully it'll help drive sort of areas that could be better potentially. So I think capturing patient experience is an important one, thinking about disease outcomes, and I would love a digital technology solution to capture all of this very simply.
It sort of feels like it shouldn't be that hard, right? I say that with a lot of ignorance, but hopefully, maybe let's watch this space. let's talk
Well,
about something that is, sorry, Alexis, please.
oh, I was going to add one more thing there. So I think there's two pieces with the capture of PROs. So one of the other things, though, is that they want to know that the PROs are being used.
Mhm.
And so if they put them in there and the provider doesn't address the PRO, sometimes they'll stop doing them because they're like, well, that's obviously not important. So I think that that is an important piece. And I think I lost my other train of thought. It's something else you said about mind the gap. Okay, I'll come back to it once it re-enters my brain again. Sorry.
No worries, it'll come to you, I'm sure. We talked, both of you in your talks actually mentioned psychological readiness. And this is a very vulnerable period of time with a lot of life events happening. Alexis, you talked about people going to college, getting engaged, lots of big life events. Mental health services in the UK are woefully underfunded. I think that's probably the same in America too. And one of the audience participants commented on this. Given how underfunded mental health services are, how do you tackle this with your patients facing mental health challenges during their transition phase? So Priya, perhaps we could kick off with you.
Thanks. Really important sort of part of managing any young person with a long-term health condition. So lots of tiers of mental health support. So almost all our IBD letters, especially for the ones that are sent out to young people, will have some information on it about how they can access mental health support and sort of I'm saying tier one, I don't know the right term, but sort of the sort of low level mental health support, which is provided, is easily accessible. Often there might be services outside the hospital in the community that are providing it. So ensuring we're signposting young people quite early. So thinking more about sort of preventative support. So we have a young person's directory of services that we try and signpost young people to. We send it as a QR code in letters. There is also a project that's run from psychologists within our organization called the Lucy Project, where it's not disease specific, it's not one-to-one, it's done as a group sort of session for any young person with long-term health condition, and it means you can use a finite resource but reach a larger number of young people. And then there will be some young people that will need that one-to-one with a psychologist, and if we think that they do, we try and get them onto that pathway and that waiting list as early as we can. And our psychologists will finish their sort of work with the young person, even if they've transitioned care, which helps, just like it did with the patient I discussed in the presentation. So I suppose 3 levels of care, and then thinking about how digital technology might help with some of this as well. Again, in the more sort of the more general mental health support, there may be a role there potentially.
Absolutely, and telemedicine probably comes into that as well, having Zoom consultations rather than having to go and attend in person might improve attendance. Alexis, your thoughts on mental health support?
Yeah, I think similarly, we do have poor overall support, although one of the nice things is that pediatric hospitals tend to have better support. So actually, that's something we try to get them hooked up with there and then keep that continuity with that same provider. So I have someone who's probably 28 now, still seeing her pediatric provider because she's been able to keep that relationship, and that's been really helpful. So that is one thing we try to do. We also have them call the back of the insurance card in the United States, and you'll get a list of potential therapists that are covered by your insurance. And so then they can make that contact. So it is very important. I mentioned it I screen for it at every single visit. I ask about depression and anxiety. I listen for the continuous fatigue too, because sometimes that's related to ADHD or other things going on, and try to make links in some way or another if it's not the sleep. But asking it every time at every visit makes kind of normalizes it and just lets them know I'm open to hearing about it. And that's a population that sometimes when I ask about it, they may say no, and then they may call me back later. I've had that happen a couple times and say, I've been thinking, you asked me this question. Yeah, I think I have been feeling a little depressed. Or in the case of a guy, he was like, I've just been angry all the time, and I think that there's something else going on. And so it was really helpful to, I think, just lay the foundation that this is just something we do here. We ask about this every time.
Yeah, that makes sense. And I agree with you that pediatrics do tend to have better access to psychological support, and that tends to dwindle and diminish and fade into kind of adolescent care. So utilizing that, maximizing the resource that we have is really important. Let's talk about medicines in a very generic sense. So we know that metabolism changes as we age, and so drug doses are often higher, like methotrexate, for example, our anchor drug. How do you handle conversations with patients and their parents if they're facing a change in their medication and dose? And that's an audience question. So Priya, perhaps we could start with you. Do you have that conversation early, saying as you age, the medication dose might change, or perhaps funding might not be available? How do you handle that?
So in terms of sort of dosing, we find that for drug dosing is generally milligram per kilo. That's how the studies have been done. But in children, that might not be fully applicable, because it might actually be body surface area, but we haven't got the sort of the calculation for that necessarily. So we do find that we're having to use higher dosages when they are younger, and then when they reach sort of adult care, they might not be needing as much maybe. And so we try and build that into conversations. And then having the joint clinics is really useful, because we can touch on that together, and we can explore that together if that comes, if we try and bring it up in conversations. If it doesn't, or if it's a question, we can try and explore it with the young person and family together. Funding, I think, again, if it's a decision, the sort of the joint clinic format helps, but even if it isn't a joint clinic, if they are transitioning, for example, to a hospital that's further away and not in Sheffield, I don't think the funding is necessarily an issue if we're following similar guidelines, at least on our pathways. So that's not been a particular issue.
Thank you. Alexis, drugs, dosing, conversations.
So our pediatric rheumatologists, I think, are fairly aggressive with doses. And so that isn't something that we have to deal with very often, is the change in dose. Most of the time, they're already getting the approved dose by the time they come to us. So I was just trying to think about having changed doses, and I don't think I've had to do that. So most of them come already on the correct dose.
Okay, perfect. There's a fantastic question in the chat about allied healthcare professionals, and the chat has been really very full, rich with lots of great questions. So please keep them coming in the last 10 minutes or so. So with the lack of staffing available that you mentioned, I think, Alexis, you talked about staffing shortages, and that's widely applicable to every specialty, every country. Do you see any role to further integrate allied healthcare professionals to aid transition, like pharmacists, dietitians, physicians associates? And if so, how do you envision this integration of allied healthcare professionals in a pathway?
Yeah, we have a nurse practitioner who does spondyloarthritis and psoriatic arthritis, and she sees these young people too. So it's a great, great asset. And then I can stop in and say hi on a first visit, especially for some of the younger ones where the parents want that. But she's a phenomenal caregiver for patients with spondyloarthritis, and it's a great resource for us. So I do love having her with us in our very specialized clinic, because she doesn't have to worry about lupus and everything else. We're very much like, this is we have a system. So it's, I really like that hyper specialized allied health professional. The other person is the nurse. So it's great to have a nurse who's trained, who actually comes in the room sometimes and sees our patients, and they know the disease. They know what, they're part of the care team, so they understand how we all function too. I think that's really helpful, just to, provide the best care possible as a team.
Thank you. And Priya, you mentioned the role of the IBD nurse in one of the cases that you discussed, integral role. Any other allied healthcare professionals, like dietitians, I can imagine, super important in IBD care?
Absolutely, dietitians, and I'd say our GI pharmacists plays a huge amount in the transition pathway. So, touching on for example, the drug dosaging, we would optimize our drug doses based on drug levels, etc., which really helps. And sometimes if we are or have, because we sometimes end up using much higher dosages, and if the patient's transferring to a different adult hospital, say not geographically distant, for example, so no joint clinic format, the pharmacists are quite helpful in liaising with pharmacists in the other hospitals in terms of having those conversations and ensuring that the same sort of drug management carries through. So I think that's a really important role. And dietetic support, I think, really key, because managing Crohn's disease, in inflammatory bowel disease, lots of dietary strategies which are useful. I think the difficulty is really good dietetic support in pediatric services, but possibly not mirrored in the adult services. So it's trying to manage that when needed.
Thank you. And I guess in the last few minutes, could we talk about what you wish the other side knew or did better? So, Alexis, how about yourself? So, as an adult rheumatologist, what do you wish things could be done better from the pediatric side to make the transitions smoother?
So I guess it's mostly about educating the patients to be more independent and able to go through a quick visit. I think the other thing I forgot to mention, one of the other challenges is they get joint injections sometimes under anesthesia, or like even they have MRIs under anesthesia. It's so funny how the face that comes over them when we tell them that we just do the joint injection right here. They're like, oh my goodness, no. So I think some of those, being aware of those kinds of things, and then transitioning out of that, I'm going to put you to sleep, to be able to do a routine injection and stuff, and to move into adult care. So, but I think, again, our group does this really well. I think we have a kind of nicely oiled machine, but when I've gotten people from other pediatric rheumatologists that are not at Penn, and it's because they're moving to college, that those are some of the things that come up. And the parents, I think, educating the parents that we're not really interested in hearing so much from the parents. We're really interested in hearing from the kid.
That's really hard, isn't it? Priya, what do you think? What do you think the adult rheumatologists or other healthcare providers could do better? What do you wish that they knew?
So I think it would be useful. Uh, so when care has finally transferred across, or when they've been seen in the adult provider's clinic, I think having information back to the children's teams is really useful, and it works. Sometimes it happens. It's well-oiled machinery, and you always get information back. But sometimes when you're transitioning to some centers, you don't get information back that care is actually transferred across. They've been seen, care has been taken over. So practical issues in terms of infusions haven't been cancelled, appointments haven't been cancelled. So the practicalities that would really help. And then I suppose the second thing might be, and again, there is variability. It's about recognizing the differences with each young person and the support they might need even after they've transferred care, which some colleagues are absolutely fabulous at, and some sort of are, they recognize it, but it's just knowing that the young person will need the support that they potentially need for that little bit longer till they are that fully functioning adult in adult services.
Yeah, that's such a good point. I think actually feeding back in terms of tying up the loose ends and making sure appointments are cancelled, and the process is more efficient. And I think for me, as a clinician scientist, I think there's a huge data gap in terms of biosamples, biorepositories. We talked about blood, Priya, with some patients only having capillary blood or needing EMLA cream and that sort of thing. But there is a wealth of tissue and samples that we could hopefully collaborate and advance the field with better research. So we're nearly at, oh, we're exactly at time. I was going to say nearly at time, but we're exactly at time. So it just falls to me to say a huge thank you to both of our speakers, Alexis and Priya. You've been fantastic. We've covered so much. There's a lot of echoes in the challenges and gaps, and actually the solutions seem to be joined up. And so perhaps we just need to talk to each other and do better. And for me, on a personal note, It's been an amazing opportunity to partner with Pfizer on this series. We've navigated so many different topics and covered an amazing array of things that are so useful in clinical practice, and had amazing speakers. Every single session has had a UK and a US speaker, and it's been absolutely fantastic to be supported by a company that is purely for education, non-promotional events. And this series, I think, has garnered a lot of interest. And thank you to the audience. Like all of our webinars, today we had a really great audience engagement, fantastic questions. And as always, the session will be recorded and available on demand at a later time. So thank you again to Alexis and Priya. It's been great to bridge the gap between peds and adults, rheumatology, gastro, and hopefully better collaborative academic and clinical working in the future. Thank you so much to everyone.